Testing, testing. Roger, roger. All right, this is probably where we should be on slide number 27, I believe. And some of this, what you're going to find is some of this material is repetitive and some of this material needs to be repetitive. Okay? I think I told you on night one that patient assessment is probably one of the most difficult modules. I really agree. I totally believe that. There's a lot of information that's in the patient assessment. All right. I guess in the initial assessment, what are the components? Just kind of thinking back and remember what, if I say you should be able to perform an initial assessment, what is the first step? What's the first thing I want to write under initial assessment?
Sick or not sick? Seems as if.
I want to write the first step is GI, not a soldier, but GI, which stands for general impression. What does general impression mean to you? The way they look. So can it be safe to say that I'm coming into your home to take care of somebody, and as soon as I walk in the door, I see the guy over there laying in bed. Can I start assessing him from across the room? Yes, I can. What am I looking for? Indicators. How do they look? Are they aware of my presence? Do they look like they're having a hard time breathing? Do they have a knife buried in their chest? And just kind of go on with that, okay? So general impression tells you a lot about your patient before you even touch them, okay? Number two, what's the next thing you're going to ask under initial assessment? Somebody said it a while ago. It is chief complaint, okay? CC, which is chief complaint, okay? Which gauges what? LOC, okay? It gauges their level of consciousness or level of responsiveness, right? In other words, if I walk in, the guy's laying in there and he's holding his chest, he's having a hard time breathing. Mr. Johnson, what seems to be bothering you today? My chest is hurting. I was mowing grass, and then all of a sudden I started having this chest pain. I came inside the house and I decided to lay in the recliner. So what does that say to me about your chief complaint? Did he answer the question? Yes. What does that say about his mental status or his level of responsiveness? It's good. Okay? Step number 3. Okay. C-spine considerations. Which means what? You always want to find out, is there a trauma involved into why you were called? In other words, you walk in to Temple College, there's a maintenance guy here, there's a ladder that's knocked over, he's laying on the ground. The ladder's a 15-foot, 16-foot ladder. Are there C-spine considerations?
Yes,
yeah, he fell off the ladder, okay? All right, what is 4? Anybody?
The ABPU.
There you go. ABCs. Because your ABPU should be up here.
Oh, okay.
Okay? In other words, and I'm glad you brought that up. A while ago we gave the example that he told me exactly what was bothering him. Let's say he's laying on the ground, there's a ladder on the ground. What's his chief complaint? Well, it seems like a fall. Somebody heard a loud noise and saw him laying on the ground. Okay? I show up, and he's got a bump on his head, and he's got blood coming out the corner of his mouth. And the lady over the vending machine said she heard him go, ugh, like that, and then she heard a thud, and she came in here, and he was doing like this. He was shaking. What's going on? Sounds like he had a seizure. So, did he fall because he was clumsy, or did he fall because he had a seizure which caused him to fall? There you go. Okay, but there's still C-spine considerations there. Okay, is he alert? He's going like this. Okay? He's not alert. Is he verbal? Probably not. If I mash on him, he goes, ugh. So he's probably responsive to painful stimuli. So if he can't do this, then we use what? One of these to answer our questions. Does that make sense? Okay. A stands for what?
Airway.
Airway. Two things I want you can write it down, two things I want you to ask when you examine somebody's airway is what do I see and what do I smell? What do I see and what do I smell? And that requires you to do what? It requires you to get close. It also requires you to do what? Ask them to open their mouth. If they're alert, say open your mouth. If they're not alert, then what do? You open it for them. Now what are you looking for?
Any obstructions?
Anything that shouldn't be there. Okay? Broken teeth, blood, vomitus, secretions, swelling, anything that shouldn't be there. Okay? So what I see and what I smell. Okay? Alcohol or sweet acetonic breath odor or maybe something that smells like almonds. I don't know. But just kind of pay attention to that, okay? All right? B stands for what?
Breathing.
Okay? Now, do we really want you in this very fast assessment to count the rate? Because how long is it going to take to count the rate? Probably at least 30 seconds. Do I want you to spend 30 seconds counting to see how many times they're breathing per minute? All I really want you to do is what? Are they breathing? Are they breathing fast or slow? Okay? So, breathing. Now let me ask you this. Let's say you check the airway, you didn't see anything, but the friends tell you this guy has had like a bottle of Everclear. What is that, 160 proof? I don't know. What do you drinkers? Tell me, what is it? What is that stuff, 200 proof or something like that? And they drank the whole bottle of that. And when you walked in the room, this dorm room, this kid was going, okay? Is there something wrong? You didn't see anything in the airway. Clearly you looked in there, you don't see anything, but you smelled a lot of alcohol. Okay? Is the airway clear? You didn't see anything. But again, I'm telling you, he's going.
Maybe it's his tongue.
The tongue's causing it. Why is the tongue causing that?
Because it's in
Because
the
he's
way.
shit-faced, right? How bad? Pretty bad. Okay? So, do you have to manage that airway?
Yes.
Absolutely. So what are you going to do with that airway? I don't have any idea, but I'm going to put something in their mouth to keep the tongue off the back of their mouth so they'll stop snoring. They're not snoring because they're tired and it's sleepy time. They're snoring because their jaw is so relaxed and it's done what? It's causing obstruction in the back of the airway. That's your responsibility. You got to take care of that. And let's say she was going, and you counted them, you go, I'm not going to count it for 30 seconds, but man, I only got like 2 respirations in 15 seconds. How often are they breathing? 2, 4, 6, 8 times a minute. Normal respirations are 12 to 24. So they're what? Breathing too slow. What are you going to do about that? What's that?
Give them oxygen.
Not only am I going to give them oxygen, because oxygen is going to help those 8 breaths per minute, but how am I going to alter that 8 breaths per minute? I'm going to start assisting their breathing. I'm going to force air into their lungs. Okay? And C stands for what?
Circulation.
Circulation. When you're checking somebody's circulation, what's the first thing you want to do? Put your arm out. I want to check here, and I want to check here. Okay? Why am I doing that? They're talking to me. Why am I checking for your pulse? Somebody? Anybody?
Because I want to make sure. Yeah.
blood pressure.
Because not always you'll find a pulse down here. You
Okay,
wanna
if you
make
fell
sure-
off the ladder and you have a pulse here, but you don't have a pulse here, what's your blood pressure?
Automatic will show that damage strong.
No.
If your body goes
Your
in
body?
If your body goes into shock.
Exactly. When your body goes into shock, your body's going to try to do what? Maintain core perfusion, or what it's going to do is it's going to maintain perfusion to vital organs. Okay. Vital organs are brain, lungs, heart, kidneys. They're all right in here, right? Okay? So is there anything important in my periphery, being my arms and legs? There ain't a heart, there ain't no lungs, there ain't no liver, there ain't no kidneys, there's nothing important there. So the body's going to start doing what? It says, you know what, hey dudes, there's nothing out here. We really like your arms and legs, but you know what, we really don't need to send you as much blood. Okay, you really don't need it. I really need to move it where? I need to shunt it, I need to move it inward to the core. Okay? Isn't that kind of cool? The body's going to do that, but we're not smart enough to tell the body to do that. Who do you think's probably smart enough to tell the body to do that? Okay, how's the brain going to do it? It's going to send a message from the central nervous system, peripheral nervous system. It's kind of targeting your peripheral nervous system. There's your kidneys. On top of your kidneys, you got these things called adrenal glands. You heard of those guys?
Mm-hmm.
And so it's going to say, hey, dude, wake up, knock, knock. And so adrenal glands go, hey, what's up? We need you to start secreting adrenaline in the bloodstream. Why? Because this guy has been in a bad wreck, and we need to maintain perfusion to vital organs. Oh, okay. Here's what I'm going to do for you. Adrenaline's going to say, well, heart rate, I'm going to speed it up a little bit to maintain perfusion. Lungs, I need you to kick in for me and breathe a little bit faster, because this guy's losing red blood cells, so he's losing the ability to carry oxygen. Okay? And by the way, adrenaline, I'm going to send some adrenaline out to your periphery. Because I know we got blood there, but I also know you got muscles and you got vascular system like your arteries and your veins. But what I want you guys to do is I want you to start shunting and making those blood vessels in the arms and legs and make them what, bigger or smaller?
Smaller.
So when I make them smaller, I'm doing what to blood? Moving it inward, and I'm sending what? Less blood out to here. Does that make sense?
Mm-hmm.
So I'm redirecting blood flow where? To the core. To what? Maintain perfusion to vital organs. And so this guy that was in a bad car wreck, the body started kicking in, and it all happened because you have two systems. You have what's called your parasympathetic nervous system and your sympathetic nervous system. You guys have heard of this, right?
Mm-hmm.
Now your parasympathetic system is called your feed or breathe. This guy's been in a car wreck. Does he want to eat a sandwich now? No. Or he wants the sympathetic nervous system to kick in. That is what? The fight or flight. Exactly. The example would be tonight when I get ready to leave, I go out to the parking lot and somebody meets me at my truck and says, and they put a knife in my back and they go, I need your truck keys. What choices do I have here? I can say, hey, parasympathetic nervous system, I want you to kick in because I want to eat right now. Or do you think I want my sympathetic nervous system to kick in? Yeah, because I want to go into the what? The fight or flight mode. I want to either fight this guy or I want to run. Does that make sense?
Mm-hmm.
Now, let's say after the police reports are done and all that kind of stuff, the guy runs off my truck, I get home, and I'm so exhausted. Do I want to fight or flight when I get home?
No.
Or do I want my parasympathetic nervous system to kick in? I just want to rest, okay? All right. So where the hell were we at? We're talking about pulses, okay? So really, when you feel pulses in different parts, I think I told you this day one, the farther from the heart that you can feel a pulse, the better the blood pressure. That makes sense?
Mm-hmm.
So if I'm still feeling pulses in my wrist, the body's still saying what? We still got enough blood flow for what? Everybody. But right now, this guy's got a crushed chest. I think he's got a liver lack. We really don't need to send as much perfusion out to here. So it'll start selectively, distal, farther away from the body, start shutting him down, making them smaller, constricting them, and sending blood inward. Okay? So, pulses is one thing we do. Capillary refill. Remember, Jeff talked about that, capillary refill.
Mhm.
And y'all know how to do that? The capillary Blanche test. Did y'all do that the other night?
No.
Okay. So what you do is take the fingernail and mash it against the bed of another fingernail bed, and mash it. It turns white, and release it. What happens when you release it?
Turns right again.
It turns back to pink within the time it takes to say capillary refill, or within 2 seconds. So, if you're evaluating somebody and their capillary refill time is less than 2 seconds, that's considered normal. Now, that's the test question we're looking for, the answer for the test question. But I'm going to tell you, sometimes I ask you to step outside the box. That 2-second caca that we talked about just now, that probably works best for kiddos. The best time to use capillary refill time is in kids, not necessarily in old people. But for the test, if it's greater than 2 seconds, it's considered what? Delayed refill time. Okay? Is that clear what I just said? Okay. So we check for pulses. What about if you're dealing with a girl and she's got fingernail polish? Then what? You can do this. Does the same thing. Bottom of her foot, probably up here on the forehead. So just mash and see if that refills. Okay? So we're checking the pulses, we're checking capillary refill time. Also, we want you to check the skin temp and quality. Is it warm and dry? Okay? Or is it kind of cool and clammy? What does warm and dry mean?
Good circulation.
It means you. Feel you. I feel good. I feel warm and dry. Now, if you were cool and clammy, that's probably early indicators of maybe shock. Okay? Anyway, they've got this on here, and we'll talk about that. All right. Now, you've heard this. We answered that on the quiz a while ago. In the initial assessment, if you find a problem, then you need to fix it, then move on. So the point I was trying to make a while ago is, let's say our general impression was poor, because the guy was laying there motionless, and this is a 35-foot ladder, and this is a firefighter laying there. So he fell 35 feet. That's not a good thing. All right? My general impression is poor. He's not responsive. Are there C-spine considerations? Yes. I get there and he's going, is there an airway problem?
Yes.
Okay, what am I going to do before I move on?
Treat the airway.
I'm going to put in an oral airway. When I get to the breathing, I find out he's breathing 2 times a minute. Do I check circulation out, or do I start breathing first?
Start breathing first.
What this says is, you find a problem, you fix it, then you move on. I will also say this. Let's say this guy's got taken a shotgun, put it underneath his jaw, and he's blowing his face away. And he keeps bleeding. His airway keeps filling with blood. And you're going to revert back to your EMT days in class, and you're going to say, well, he said you do airway, breathing, circulation. But I'm also telling you what? You find a problem and you fix it. If you can't fix it, then what?
Transfer.
Circulation is really not that big a deal, is it? Checking their head and their arms and legs is not that big a deal. What's important? Managing these things up here. So if these aren't fixed or fixable, then you need to get moving with them and get them to somebody who can fix them for you. Okay? So what I'm saying to you is you may never complete your assessment because I'm taking care of the initial assessment components, right? All right, in the initial assessment, you can do something called a rapid transport. And in rapid transport, what that really means is I recognize a critical patient, so I need to get them to the hospital. Because I realize that there's nothing I'm going to do to change to fix them. I may stabilize them, but I ain't going to fix them. Let's say I show up as a paramedic. Am I going to fix them for you? No. Let's say a critical care nurse shows up. Is she going to fix them? Unless she can do surgery, the answer is no. So we all collectively know that there are certain patients that we can't fix. We might patch holes and we might stabilize you, but the real thing is we need to get you to the hospital. Now, it's okay in some cases to consider an ALS intercept. So that means I'm out in Holland, I got a bad car wreck victim, the fogs come in, I can't get a helo service out here. So what I'm going to do is I'm going to haul you to the hospital. Scott and White sending an ambulance from Scott and White. But I'm not going to wait on scene until you get to me. What am I going to do? I'm going to get going, and about halfway between here and Scott and White, Temple, between Holland and Temple, then I run to the ambulance. They get out of their ambulance, they get in mine, and we transport the patient. Okay? That's an ALS intercept. And why am I doing an ALS intercept? Because the basic, I couldn't start any IVs. I was plugging the holes. But as far as shock management, I'm not starting IVs, and I'm not giving them vasopressors, and I'm not doing any of this stuff. I'm just going to really, stabilize them. Well, maybe when I get that ALS crew, they can do additional steps, but we're not going to stop so that you can do all this cockeying. We're going to, you get in my ambulance, we keep going to the hospital. Okay? And again, like I said, I mentioned that second bullet there. If you can't manage them, then hand them off to somebody who can. Okay, this is the criteria for a rapid transport. Somebody who generates a poor general impression. And what in your mind is a poor general impression? Just look at this right here. If there's something wrong with their mental status, that's a poor general impression. Okay? If there's an airway issue, a breathing issue, a circulation issue. So those are pretty simple. So, again, unresponsive, airway issues, breathing issues, poor perfusion. What does poor perfusion mean? Capillary ventricular time is 6. Is that poor perfusion? Mm-hmm. Yes. I have no radial pulse. Is that poor perfusion? Mm-hmm. Absolutely. Severe pain in any part of the body, severe chest pain, inability to move any part of the body. That could be kind of a neurogenic thing, okay? It could be a spinal cord injury or something to that effect. Some others might be a complicated childbirth. Okay, most childbirths that I've had have been pretty straightforward. But now when you look down there and you see an arm or a leg sticking out, this is not a steer, this is not something I can, or a cow, whatever. This is not something I can stick my hand in there and change the mechanics of this. I'm not going to do that, okay? If I have a complicated childbirth, I'm going to get them to the hospital, all right? If they're hyperthermic, did I say that right? Hyperthermic, okay, that's correct. Hypothermia, so if they're too hot or too cold, maybe they got stung by like 200 bees, and I'm not allergic to bees, but my system can only take so much. I can take probably 10 bee stings at a whack, but I'm not going to do well with 200 bee stings. That's going to overwhelm most systems. Or it could be something as minor as I get a fire ant bite, but I'm extremely allergic to it, and I go into anaphylactic shock. Poisoning or overdose of an unknown nature. Oftentimes when we pick up poisonings, Sometimes we know what it is, but sometimes we don't because the patient's unresponsive. Maybe they try to hurt themselves, and they not only take one agent, but they take multiple agents. All right. So we've talked about scene size up. Let's kind of refresh our memory here. All right. Let's go in reverse for a second. Scene size up. What are the components of a scene size up? Is a scene safe? Okay. BSI, MOI, which stands for what? Mechanism of injury. How many victims do I have? And do I need additional resources? Now, in the future, when I say, what is a scene assessment? What are the 5 steps in a scene assessment? Those are the answers I'm looking for. Okay? So you should know those. Now, we just went over initial assessment. What are the steps in an initial assessment? GI, which is general impression, chief complaint, spinal considerations, airway, breathing, circulation. It's that simple. Don't complicate it. Because if you read that, the book, the chapter, is that overwhelming material? Yeah, it is. There's a lot. So I'm trying to clean it up for you and say, this is really what I need you to get out of that section. Okay? It says that you are here, you're going to do a focused history or physical exam. Now the difference between a focused history and a physical exam is pretty simple. I walk into your home and you were slicing tomatoes and you cut your finger and your finger's bleeding. You call me for this crap? No. But your finger's bleeding, okay? Now, do I need to take and squeeze this lady's head and shine a light in her eyes and her ears and her mouth and listen to her breath sounds and feel her belly? Do I need to do all that crap?
Only if she's going into shock, you want to actually check her.
If she cut her finger, that's all. Don't complicate this. She just cut her finger. She just cut her finger. The question is, do I need to do all that stuff? The answer is no. That's when I make the decision to do what? Something called a focused assessment, which is what? I'm going to focus on this, your injury. Okay? I think the other example they might use is you have an athlete, a cross-country athlete, that was running and rolled his ankle, and he's got an isolated ankle injury. You get there and you're a good EMT, so you check their blood pressure and their respiratory rate and their pulse rate is 42. Ooh. Now, are you going to get wigged out? Because you know that normal heart rates are between 60 and 80 at rest in an adult, and maybe up to 60 to 100 is still considered normal. Again, the question is, they have a heart rate of 42, are you going to get wigged out?
No, that's
Please don't get wigged out. Why? Even though that's low, that's low for a what? Normal population. I mean, if it's 60 to 80 is normal, but that's low. That's normal for a person that is that well conditioned. So don't get wigged. Focus on what? I sprained my ankle. I rolled my ankle. Okay. All right, and then a physical exam. Let's say the lady cutting tomatoes cut the tomatoes, and she goes, oh, and passes out, whacks her head on the corner of the countertop there, and I get there and there's blood, the pooled blood this big around her head, and she's got this huge gaping hole in the back of her head. I'm going, my God, why is she losing so much blood? She's about 60 years old. She's had a heart valve replaced, so she's on blood thinners. Does that make sense to you now? Now, does this lady need a full physical exam? Or do I still just need to check this one finger she cut? Does that change the scenario? Absolutely. Okay.
Check the finger.
What's that?
I said check the finger.
Yeah. All right. And then we'll talk about the others in just a bit. So the focused history and physical exam can be you can actually do both of them, okay? For example, and you're going to hear me kind of change the terminology a little bit. Because I believe, and what I'm going to teach you guys, is that when you have a trauma patient, GSW to the chest, gunshot wound to the chest, you know, I need you to do a full body exam, okay? On the other hand, if you walk in, this guy's complaining of chest pain, and he's 60 years old, and he's obese, he's got diabetes, do I want you to do a head-to-toe exam on him? I'm going to want you to use a format very similar to it so that you remember it, but I'm going to ask you to do that assessment slightly different. Okay, and I call it a modified physical exam. Okay? So the purpose of this stuff, again, is to find out what happened to the patient, what circumstances surrounded the incident. Okay, when people fall, do I automatically assume it's just loss of balance or clumsiness? One of the first questions I ask is, why did you fall? I had a little old lady was shopping yesterday. Fell in the parking lot. Huge gaping laceration to her chin, huge hematoma side of her face, and it would be easy if you walked up on that patient and goes, "Oh, I got to take care of this blood, and I got to do this, and she's got a silver fork fracture right here. She's got a lot of stuff going on." The first question I asked is, "Did you just pass out?" She goes, "Yeah, I just passed out." Ooh, that's different for me. I look at your age. I'm thinking. And I'm going to put you on a cardiac monitor. Why does this old lady need to be on a cardiac monitor? Clearly she has a broken wrist. She has a big, huge hematoma here and a lac here. People are probably going, "You idiot, why aren't you taking care of the stuff that needs to be taken care of?" Is this stuff going to kill her?
That's the
No.
She
Is
passed
the
out.
fact that she's got a heart abnormality which caused her to pass out, is that going to kill her?
Yes.
Absolutely. So you guys need to be able to stick and move. Why did this happen, okay? Now the second one is a mechanism of injury at a high risk for injury. What does that mean exactly? Sometimes, I'll give you a good example. And I'm sharing information with you simply because I want you guys to learn. One of the calls we made recently was a van that went across the highway, and it's resting very close to a wall, almost ran other vehicles off the road. We get there, the victim slumped over behind the steering wheel. Vehicle's still running. There's not a scratch on this vehicle. We get to the patient, they have no pulse, they're not breathing. Is this a medical call, or is this a trauma call?
I would call it
I would treat it as
medical.
both.
Okay, the only thing that I see on her is just a small amount of trace blood coming from the corner of her mouth. The first thing I'm thinking is she's had a seizure, but all that stuff is distractors. Bottom line is she has no pulse, she's not breathing. So what am I going to do? I'm doing CPR. I don't care about the car wreck. I don't care about the distractors. In life, we will throw distractors at you. That's exactly what they are. They're designed to get your attention away from what you should be looking at. Okay? And so we started CPR on this lady, and there's not a scratch on the vehicle. So what I'm telling you is, even though it looked like a car wreck, even though she lost control of her vehicle, there wasn't enough damage. Hey, there wasn't any damage to the vehicle to cause her to die. So it sounds to me like she died and then lost control of her vehicle. Does that make sense? So you need to ask yourself those questions. Very important. Now, because this brings up this point. This vehicle didn't have a scratch on it. Is that a high mechanism of injury kind of thing?
No.
Let me give you a different example. Let's say you go to a car and there is 22 inches of displacement. Let me explain what displacement is. This is the front bumper of my car. I'm driving my car. I hit a telephone pole. My front bumper is pushed in 22 inches from where it should have been. Is that a high degree of, should that create a high degree of suspicion to you?
Yes.
Let's say you get there and they're alert and talking to you, and they go, "I'm okay, but my chest hurts a little bit," and you open their shirt and there's a big bruise right there. You have a high risk for injury right here. They weren't seat belted. This is an old clunker. which doesn't have airbags. So what does that mean? Their chest probably hit, and I checked for a pulse like I'm supposed to, and it's very irregular. Is this looking ugly to us?
Yeah.
Absolutely. All right. It said you should conduct the physical exam, and again, the physical exam is what we call the head to toe exam. I don't know if Jeff got to that part, but it's an exam that we do where we check from head down to toes, and you want to obtain something called baseline vital signs. Did he talk about that? Okay, baseline vital signs are the first set of vital signs that were taken. Hey, they could have been taken just before you got there. So I walk into a nursing home, and the people at the nursing home say, this lady was complaining of chest pain. The nurse gave her a little nitro before you got here. And by the way, this is the first set of vital signs we took. Thank you, I need those. So those become what? My baseline. To do what? I can compare future vital signs too. Because when you give the nitro, the expectation is that it's trying to make the chest pain go away by dilating the blood vessels. But in order to do that, it's got to dilate all blood vessels. And when that happens, it's probably going to drop your blood pressure. Okay? So I take those vital signs, and 5 minutes later I take a repeat set of vital signs, and I find out their blood pressure's dropped. Her chest pain is decreasing, the blood pressure is dropping, and this old lady has a headache. Voila, what's happening? The nitro's doing what it's supposed to. It's not supposed to give you a headache, it's just a side effect. Too bad. Okay? It may drop your blood pressure because it dilates your blood vessels, okay? And it may relieve the chest pain because it's opening up coronary blood vessels and allowing better blood flow, okay? All right, so yeah, get those baseline vital signs and find out where they're at. All right, the approaches to physical exam. There's three kind of routes we can take, and I'll give you an example to each one. So when I do this head-to-toe exam that we're talking about, I can do it very fast, which is called the rapid trauma assessment, or I could do what's called a detailed head-to-toe. A cheap example would be, my wife says, hey, would you wash my car? Sure, great, whatever. And so I go wash her car, and I want to just get this thing done with. So I've just met the standard. She just wanted to wash, that's what I'm going to do. But next week she goes, you know what, I'm thinking about selling my car. And what do I want? I want as much money as I can get for that car, right? So what am I going to do? I'm going to get a detail, which means what? I'm going to pay a lot more attention to it because I want to get the value up on the car. Well, with patience, okay, and let me give you an example. You walk into a bar fight, your patient's lying there, and there's blood around them, they got 2 GSWs to their chest. Do they need that detailed head-to-toe exam that's going to take me forever, or they need a rapid trauma assessment?
Rapid trauma assessment.
Exactly. So a rapid trauma assessment, I do that very quickly. You just get kind of skate through and say I got it done. And I'm still looking for life-threatening injuries, and I'm still going to fix them or patch them. But that's what I'm trying to do. And then the other thing is a focused assessment, which means what?
On the one
I
area
cut
that.
the there you go. I sprained my ankle kind of thing. Is chest pain a focused assessment? Yeah. Is I'm having difficulty in breathing a focused assessment?
Yes.
Sure, absolutely. Okay. So I was asked this question. If you were to call the hospital and say, I have a victim of a fall, how far did they fall? Well, it's pretty simple. What's the door jam? About 7 foot, right? Here to here is what? Another, what, 3, 4 feet?
Mm-hmm.
So what is that, 10, 11 feet? How far they fall?
Well,
Okay, that sounds reasonable. Let's say I evaluate him. He's got a big old laceration to the head, which means his head hit the floor, and he's 6 foot tall. How far did they fall?
18 feet.
You add his height to the fall. Okay? So the question is there a significant mechanism of injury here? Yes. Okay? Questions, are the patients responsive or disoriented? Can they participate in the examination? In other words, they follow commands, sir, move your arm and leg, blah, blah, that kind of stuff. Is a patient under the influence of drugs or alcohol? Does that have any bearing on what we're going to do?
Maybe.
I would say
A lot of
yes.
people go, they go, I'm hurting. Well, it's just because you're drunk. Or they may say, I'm not hurting. And well, you're not hurting because you're drunk and you just don't feel it right now, kind of thing. You've heard that before, right? So again, try to keep the alcohol kind of thing out of the equation. You want to mention it to the receiving hospital, but understand they may not complain of any pain or discomfort, and they may really be suffering, okay? Or it's really easy to say, oh, the reason you're acting goofy, because they could have an altered mental status, which looks like what? They're intoxicated. So be careful with that. So the question, the statement is, never just assume that somebody's under the influence. Assume that the reason they're acting like a goofball is because their sugar's low, or they whacked their head and they've got a head injury. Okay, so there could be multiple reasons there.
Why do you act goofy with low sugar?
What's that?
Why do you start acting goofy with low sugar?
Because the brain needs two substrates, oxygen and glucose. Okay? If they don't have glucose, which is sugar, you act like a goofball. The other thing too is you can act like a goofball if your sugar's too high. And the reason that happens is because you start producing acid, and acid changes your pH, okay, and you start acting like a goofball. Okay? So again, when somebody's acting goofy, I'm going to check their sugar. I've walked into a nursing home and somebody says they're acting a little strange, but they're not a diabetic. And some of my people said, well, we don't need to check their sugar. I don't give a damn. I want you to check their sugar. Okay? In other words, checking somebody's baseline glucose should be a basic vital sign. In fact, I'm going to insist it's a basic vital sign in this class. So when you come into my station and we're doing scenarios, and I say they're acting like a goofball, first thing that needs to come out of your mouth is what?
Check sugar.
What's their sugar? Okay? In fact, you're going to keep saying, what's their sugar? And I'm going to jack with you, but I want you to ask that question. Okay? All right. And so here are the components to a rapid trauma assessment. It says that we're doing something called a head-to-toe physical exam. Starts at the head and should finish somewhere down here at the bottom of the body. We're checking everything in between. We're actually looking for other life threats that we haven't already identified in the what? The initial assessment. And we're going to use the senses of palpation, auscultation, and those other senses that God gave us, mainly common sense, okay? Put all this stuff together. That's what that means. You're going to hear this. We're going to say decap BTLS. And that's the little mnemonic for deformities and contusions and abrasions and punctures and penetrations, burns, tenderness, lacerations, and swelling. At some point you need to learn this. Not tonight, though. Okay. When you take the patient's baseline vital signs, you always want to take more than one set. Why? You want to have something to compare it to. And you want to look for trending. Trending is what? What do I think might happen to this blood pressure? Guys sitting out there in the hallway with 2 GSWs to the chest and their blood pressure is 130 over 80. What do I expect that blood pressure to do? There you go. It's trending, okay? I give this old man nitro because he's having chest pain. His blood pressure is 130 over 80. If my nitro is good, what do I expect that blood pressure to do? Okay? I get over here. This kid's got a lacerated liver, and I've got 2 large bore IVs, and his blood pressure is 70 over 40, and I've given him 2 liters of fluid. What do I expect that blood pressure to do? Go up. There you go. All right. Patients without a significant mechanism of injury. Again, you want to check the chief complaint. Listen to them. Why did you call me? You might want to do a focus exam, baseline vital signs. We talked about that. And you dang sure want to do this stuff right here. Okay? You want to do the sample history. Again, S is signs and symptoms, A is allergies, M is medications, P is past pertinent history, L is last oral intake for a menstrual cycle, E is events. Okay, we just talked about the OPQRST. O is what? Onset. P is provokes. Q is,
Quality,
R is,
Reach
and radiation or relief.
and relief, the third R. And S is,
Severity,
meaning,
how bad's the pain? On the scale of 0 to 10.
thank you. And T is time. That's sure. Okay, we talked about that. Signs and symptoms. Again, a sign is something you see, hear, smell, and feel. Symptom is something they tell you about. Again, on the allergies, what? Are you allergic to it, and what kind of reaction do you have to it? And these are some of the things they could have allergies to. Okay, medications. Again, are you taking them? Did you take them? What are the names of them? How do you spell that stuff? Okay, and all that kind of stuff. Again, don't be afraid to say, "Can I see them?" Because what you might find out is the reason they act like a goofball is, and you read that script, and it was filled 2 days ago. It has 50. It only has 2 left. What's going on here? They're over-medicated, okay? Now make sure they didn't just go put them in those little pill strips and things like that. P.S. Here's what I'd like you to do here. Under here, I want you to write these things. Heart, respiratory, high or low blood pressure, diabetes, and seizures. Okay, now here's why I asked you to write that down. Because you're going to be tempted 6 weeks from now, when you're in the ER, to walk into room 3 and say, "Mr. Johnson, I'm here to do an assessment on you. Are you allergic to anything? No. You take any medications? Yes. Blah, 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 blah. Okay? Do you have any medical problems I need to know about?" And in all likelihood, what's their answer going to be? No. Okay? Then the doctor walks in behind you because you got 0 answer to that question. He says, "Mr. Johnson, do you have any heart problems?" "Yeah, I had a heart attack about 2 years ago." Okay? Do you have a history of respiratory problems? Yeah, I have chronic bronchitis. Do you have high or low blood pressure? High blood pressure. Do you have any seizure disorders? No. Are you diabetic? Yeah, I just started Micronase about 2 months ago. So why is it the doctor got all the information and you didn't get squat?
Just the specific questions.
Ask specific questions, right? And so when you ask specific questions, you're going to get specific answers. To the point that you may walk in and ask a patient, "Do you have any medical problems?" "No." And you look at their medication list, and they take hydrochlorothiazide. Anyway, hydrochlorothiazide, which is for high blood pressure. And you just ask them, "Do you have any medical problems?" They go, "No." Now, the reason they tell you I don't have any medical problems is because I have a medical condition, but it's controlled with medication, so therefore I don't see it as what?
No problem.
There you go. So, I would prefer, actually insist, that when you get to this past pertinent medical history stuff, you need to ask these categories. And I guarantee you're going to get a lot more answers. You're going to walk away an informed EMT. Last oral intake, what they took, when they took it, things like that. And then what was the other L? Menstrual cycle. Don't be afraid to ask that question. And E is events leading up to the incident. What happened? When did it happen? Because you were going to get conflicting stories. You're going to get the family version of the story and the patient version of the story. There's probably going to be some differences between the two. All right, OPQRST. When and how did the symptoms begin? In other words, was it acute or was it gradual? Provokes. What makes it worse? In other words, they go, you know, when I get up and walk around, I get short-winded again. So that obviously provokes it. Quality. They need to describe what they feel. Again, I hate these words. Okay? Just describe to me what you feel. Because they may say, I just feel pressure. It's hard to describe, something like that. Again, it says, do not lead the patient. Don't say, does it feel sharp and dull? Squeezy, achy kind of thing? Point to where it hurts. Does it move away from there? And did you take anything to make it go away? The relief. And again, on severity, on a scale of 0 to 10, how bad is your discomfort? 10 being the worst you can imagine, and 0 being none at all. Again, I'm starting to use the words discomfort. Tell me what you feel. Don't be leading. And again, how long have you had the symptom? You might find out that they've had difficulty in breathing with associated pain in their chest for the last 3 days. And they got a low-grade fever. And they are elderly in a nursing home. And they probably had a choking episode 3 days ago. So now they have aspiration pneumonia, which could look, in some cases, like maybe chest pain. Okay, associated symptoms are what you expect to see if somebody's having a heart attack. Well, you expect them to be having some kind of discomfort. You expect them to be nauseous. You expect them to be diaphoretic, in other words, profuse sweating. You expect them to have maybe some radiation of pain. So those are the associated symptoms. In other words, you could have somebody that you think's having a heart attack, but they don't have any of the other normal signs and symptoms that you normally see with that. Does that make sense? Mm-hmm. Some associated kinds of things. Pertinent negatives, on the other hand, yes?
I just have a question. Because just from working at Scott and White, I know that females can have other symptoms like their back hurting or...
For heart attacks?
Yeah, for heart attacks,
Oh,
and not
absolutely.
have the chest pain
Oh,
and the arm.
absolutely. And there women and men are different beasts altogether. Okay? They're just 100% different. And one of the big things women like to do is they like to get very diaphoretic. They like to break out in sweat. Okay? So you're right. There are differences, many differences in men and women, especially with heart attacks. Pertinent negatives. These are expected complaints or problems not given by the patient. All right, we talked about the, now we're at medical patients. So with medical patients, you need to do a sample history, focused medical assessment, which we'll show you how to do, baseline vital signs, transport decision. Transport decision means, okay, and we're probably going to use things like priority 1, 2, and 3. Priority 1 and 2 are your higher levels of transport because you have an acute patient, you need to get them to the hospital quickly. Priority 3 patient is one that's not so critical. In fact, they're not critical at all. They're better than stable. They're not really that sick. Okay. A detailed physical exam, again, what's a detailed physical exam? Is that a head-to-toe assessment?
Yes.
Yes. Is that a very long, prolonged, protracted physical assessment?
Yes.
Right? And the opposite of that, the opposite of that is what? The rapid trauma assessment. So you either do one very fast, or you do one very slow. Okay? So we get down to something called the ongoing assessment. Ongoing assessment means I've done everything else. I've done my scene assessment, I've done my initial assessment, I've made my transport decisions, I've started treating them, I'm en route to the hospital with them, and so it says it's an ongoing assessment. So an ongoing assessment sounds to me like I'm going to take the key parts of stuff already done and reassess them. That make sense?
Mm-hmm.
So do I reassess their mental status? Yeah. Do I reassess their airway and breathing? Yes. Do I reassess if I gave them glucose, for example, oral glucose, because their blood sugar was too low? Do I do another finger stick on them?
Yes.
Absolutely. And you go on and on and on. If I've given them nitrogen to make the chest pain go away and they were a 10 out of 10, now they're 5 out of 10. So that's kind of what you do. You reassess the important parts of things you've already done. Okay. Now remember, with unresponsive patients, you're really going to have to rely on who?
So,
If you've got family, absolutely. If you've got them, use them. Sometimes what you might find is they're not very educated when it comes to what's really wrong with their family, okay? And they may just be scared too, okay? So sometimes they're they're very good allies and they give you a lot of information, but don't count on it, because sometimes they're not going to give you any information. So now you're going to have to be Dick Tracy and go start figuring out what's wrong with them. All right. It says detailed physical exam. Remember we told you it was a more detailed head-to-toe examination, and it's time sensitive. In other words, because I can spend more time doing it, if I've got a critical patient, I'm not going to do it on scene. If I can do a rapid head-to-toe exam in 90 seconds, and it takes me 3 minutes to do a detailed physical exam, am I going to do that detailed physical exam on scene?
Mm-hmm.
I'm probably going to do it en route. So that's what it tells you. It's the detailed physical exam is required for any unresponsive patient and any multi-trauma patients. What is a multi-trauma patient, by the way? Very good. I also call them multi-system trauma. So an example would be somebody who's in a car wreck and they got depression to their skull, so they got a closed head injury. They got a spinal cord injury by virtue of the mechanism of injury. This side of the chest is not rising when they breathe, so they got a chest wall injury. They're very tender to palpation when I palpate their abdomen, and they got 3 broken bones. That's multi-system trauma. In other words, there ain't just one system broken, there's a bunch of broken. Okay, required for any patient with significant mechanism, that's a detailed physical exam. Mechanism of injury would have caused serious injury. The EMT must actively assess for additional injuries. Have I gone on like really long? Did give you another break? Is it time for a break?
It's been an hour and 4 minutes.
It's been an hour and 4 minutes?
Mhm.
Let's take a break.
we'll have more pages up.
Huh?
We'll have more pages at the end of the session.
All right, I like the spirit. Let's just finish this. Okay, and the ongoing assessment, we talked about that, and we said the purpose of that is to see if there's any changes in their condition. And the way we find that is, again, recess their ABCs, their mental status, their blood sugar, their level of pain, their oxygen saturations, because they had difficulty in breathing, they had asthma, we gave a breathing treatment. We want to make sure those saturations are no longer in the 80s, they're now in the high 90s. Okay, so those things we're looking for. Do we check, recheck their blood pressure again?
Yes.
Yeah, so those are all good things we want to look at. And again, these are the things that we just mentioned. Repeat the initial assessment, their vital signs, their focus assessment, and go ahead and check interventions. The things that I did for them, are they helping you? Are they making improvements? Okay, good. Now let's talk about Placed on vital signs, and man, their blood pressure and that kind of stuff, and I don't start getting wigged out about you until your blood pressure drops and your heart rate does this and all that kind of crap. There's some validity to that, but what I'm telling you guys is just please use vital signs as a part of the decisions you make on your patient's behalf. Okay? And here's the example. When somebody is involved in a car wreck, they hit their steering wheel, what's going to happen is their body's going to go into the sympathetic drive and start dumping epi, so they're going to get naturally tachycardic. Their heart rate is, again, it's going to get faster, the respiratory rate's going to speed up, and their blood pressure may spike, and it may actually elevate. And you get there 5 minutes later, and there's 36 inches of displacement to this car, and you're going, oh, their blood pressure is 136/90. They're okay. Why is their blood pressure 136/90? It's doing what it's supposed to do. But let's say they got a lacerated liver, because we can't see that. Okay? So the progression here is that lacerated liver is going to start dumping blood, and eventually their blood pressure is going to, maybe 30, 40, 50 minutes from now, it's eventually going to drop, but everything's going to elevate to keep that blood pressure up as high as it can, as long as it can. Okay? So what I'm saying is the incipient stages of an insult to the body, yeah, that blood pressure looks pretty good. And there may not be that tachycardic, so you may put your guard down and go, you're okay. Don't think that way. Think, hey, your buddy in the same car with you is dead. Why ain't you dead? Why did you survive? Why is your blood pressure 130/90? Well, why don't you hang around about 30 minutes and I'll get it down to about 60/40 for you. That's what you need to get your attention. That's what you need to get your attention. You know what I'm saying? So look for subtle changes in patients. Okay. And so these are the things we look at: their pulse, blood pressure, respirations. And again, what we want to do is we want to look at those and compare those to future blood pressure and pulse and respirations that we take. Okay, and really what we're saying here is we talked about those trends. Look at the trends. Are things changing? Are they moving the direction that we expect them to move and stuff like that? And it always says that you should take at least 2 sets of vital signs. Okay? Are you going to take a set of vital signs on a dead person? There ain't no vital signs to take. So when we say always take 2 sets of vital signs, within reason. If you're doing CPR because this person lost control of their vehicle and they had a heart attack before they hit the wall, vital signs aren't important. They ain't got none. Okay? All right, we talked about the pulse points. And again, clearly what we want you to know and understand is if you can feel a pulse farthest from the heart, the better the blood pressure. Okay? So in the neck it's 60. Right here, brachial is what? 70. And this is what? 80. Again, neck is what? 60. Femoral is what? 70. Popliteal is what? 80. Dorsalis pedis, top of the foot is what? Yeah, just go 10. 90 right there. So the best pulse you can feel, the highest blood pressure you're going to get by feeling a pulse is what? Top of the foot. Okay? So the good Lord intended, if I'm going to still send blood to my foot, my blood pressure is still at least 90 for now. All right? That's all you really need to take away from that. Don't make it complicated. Actually, it's kind of interesting. I was working with some nurses the other day, and I kind of went over that, and they go, we never heard of that. Thought that was kind of interesting. Okay? All right. Dorsalis pedis is right here at the top of the foot. Posterior tibial. Okay? And it's real easy anatomy. Okay? Remember, you have the tibia and the fibula, and this is anterior to front, and back up there is what? Posterior. So right in here is what? Socks aren't inside out. Okay. So it's posterior tibial pulse. Now about 30% of the population, this is really a hard pulse to feel. So go to here. If you can't feel this, you can't feel this, then do what? The capillary refill. Okay? All right, for pulses, We talked about those briefly. Normal pulse ranges for the adult at rest is between 60 and 80. 60 to 100 is still considered normal. 80 to about 110 for children. And infants 120 to 150 beats per minute. So if I were to say to you in a scenario, you have a 2-month-old and their pulse rate is 52, what would I want you to do? I would want you to do CPR. And you go, wait a minute, are you whacked out? He's got a heart rate. What's his heart rate? 52. What's his normal supposed to be? 120 to 100. Are they a little bit behind here? They're a lot behind, okay? In fact, they're so far behind, they're not even perfusing. So that's why I want you to do compressions. What we check in pulses and get in the habit of checking this, I'm going to say, feel your pulse, count it. What is it? What's the rate? You're going to go, oh, it's 60. Always say the pulse is 60, the rate. The rhythm feels either regular or irregular. And the quality, it feels one of these, full, and I can feel it really well. Weak and thready, I'm having a hard time feeling it, okay? Or bounding, like if I just ran up the stairs 10 times, then my heart would go boom, 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 boom. And so I would feel that's going boom, 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 okay? So that's kind of the difference. So again, always report the 3 descriptors. Tell me something about the rate, the rhythm, and the quality, okay? Now, if you said their pulse is 62 and it's irregular, that should raise a red flag. What red flag are we looking for here? Think about it. The answer is, who creates the pulse? There you go. There's your answer. So if you have an irregular pulse, what does that mean? Something's not going right with the heart. Now, the answer may be that, hey, I have an irregular heartbeat to begin with, or it might be, no, I don't have atrial fibrillation. I'm supposed to have a regular heart rate. So what that means is, if you're the EMT crew on scene and I walk in as a medic, you need to tell me what? I think you need to put them on a heart monitor because they've got an irregular pulse. That makes sense. All right. We talked about that. Fast heart rate is, remember, add the prefix tachy in front of the heart and brady in front of it. It makes it slow or fast. So what's the range here? 60 to 100. I just mentioned that. What did the slide say a while ago? 60 to 80 at rest is considered normal. But 60 to 100 is also considered what? Normal. Thank you. All right, respirations. Now, I want to do this disclaimer right now. You're going to see somewhere between 12 and 20 in some of the literature, some of the slides. Again, 12 to 24 is considered normal. So somebody's going to say, but I read somewhere it said sub 12. It's not 12 to 20. I'm saying, what did I tell you in the class? Between 12 and 24 is considered normal. Okay? Look at children. They're a little faster. Look at kiddos. Man, those little suckers can breathe 30 to 70 times per minute. Again, in a scenario, I tell you, your kid's breathing about 22 times a minute. I'm sorry, your infant is breathing 22 times a minute. Is that normal?
No.
It may be normal for an adult, but 22 times per minute is what? It's considered what?
Low.
What's a fancy medical word for that?
Abnormal.
That's hard.
Yeah.
Bradypnea. Bradypnea. There you go. There you go. All right. All right. Respirations. Again, you want to count the rate. How many times they're breathing per minute. Okay, remember a respiration has 2 parts to it. Inhalation and exhalation. That's one breath. It's not 1, 2, 3, 4. Okay? A cycle is inhalation and exhalation. One breath. Okay? Again, is the breathing regular or irregular? Is the quality, is it full? This is full. This is deep. This is shallow. How many times did I just breathe? Poop. Attaboy, you caught it. Okay? This is labored. What am I using?
All your
Something called accessory muscles. You're right. All the muscles the good Lord gave me to help me in breathing. The biggest muscle He gave me for breathing was what? The most important muscle for breathing is what? The diaphragm. And then you have all these intercostal muscles. Then you have these accessory muscles. Then you have nasal flaring. All these accessory muscles to breathe. And then of course it can be noisy breathing, wheezing, gurgling. Something's not cool when you breathe. All right. As far as the blood pressure, okay, you have two values. You have the top number, which is also called systolic, and the bottom number, which is called diastolic. And all this really is doing is measuring the contractile force of the ventricle. You remember heart anatomy, you've got two little chambers up here and two down here. These up here are called atrium, these down here are called what? Ventricles. Now, if I were to say to you, I'm going to let you take two chambers of the heart, you can either have the upstairs, the atrium, or you can have the ventricles. How many of you say, I want the atrium? How many of you say, I want the ventricles? Okay, some of you didn't raise your hand. Now, why do y'all want the ventricles?
Because they're what pumps the blood.
Exactly, simple answer. That's my man. Simple answer. Where do they pump blood to?
Arteries, body.
Okay, very good. Yeah, the heart is actually four pumps put together. Top atrium, lower ventricles. The ventricle on the right side is sending blood to my lungs. The ventricle on my left side is sending blood where? To the rest of the body. There you go. Okay, so again, we're measuring ventricular contractile force. So it says the systolic pressure is the pressure on the arterial wall when the heart contracts, mainly the ventricles. And diastolic, or the relaxation phase, is pressure on the artery when the heart is at rest. Okay, there's a gap. There's a distance between the 120/80. So let me ask you this. If these two numbers start really spreading apart, is there a problem? Probably so. If they start getting close together, is there a problem?
Yes.
There you go. All right. We have something called auscultated blood pressure, which is what you probably had done to you over the years. Somebody put a stethoscope in their ugly head, and they put that little diaphragm on your antecubital fossa there, and they pumped that sucker up to like 600, and then they released the cuff, and they took your blood pressure, right? Doesn't that piss you off when they pump that sucker up to 600? Actually, don't go to 600. It goes to 300. But sometimes they go up to 300. That's just the stupidest thing I've ever seen. And I really just want to slap people that do that to me, because that hurts, doesn't it? Not only does it hurt, but what does it also do? It's going to give you a higher blood pressure than you're supposed to have. Absolutely. Okay, you only pump it up to what it's really necessary to listen. Okay, so again, auscultated means, the word auscultate means to what?
Listen.
Very good. Palpate, on the other hand, is what's missing in this picture. An auscultation device, a stethoscope. So we're actually going to take a blood pressure, what? Using the tactile sensation, your fingers, okay? No stethoscope here. So a while ago, we're going to get two numbers. We're going to get the top number, get the bottom number. We're going to get systolic and diastolic. Here, you get what?
Systolic.
So if I tell you to do a palpated blood pressure, you tell me it's 120 over, I'm going to say, how in the hell did you get that without a stethoscope? I'm going to have to throw the BS flag on you, okay? All right. And this kind of talks about normal, average blood pressures. Yeah, it should be. In males, one of the things you can use is 100 plus their age up to 50 over about 80. For females, it's a little less, 90 plus their age up to 50. And again, I don't think they have any test questions about what's the average blood pressure of a child, but you kind of need to know what how to formulate an adult blood pressure. And again, it's 100 plus their age up to about 50. And who's the best gauge for blood pressures? Have you ever had your blood pressure taken and you look at the nurse and say, "What's my blood pressure?" And they go, "It's all right." Oh God, that pisses me off. How do you know it's okay? Why don't you tell me what it is and I'll tell you if it's okay. I'll tell you if it's normal or abnormal. Because as I get older, guess what? I'm pretty aware of what my blood pressure is right now because I'm on medication for it. So I know where it's supposed to be. When a nurse says to me or a doctor says to me, "It's okay," give me that information. You have the right to know that. So don't ever do that to your patients. They go, "What's my blood pressure?" And you go, "It's okay." Okay? All right. All right, and then we have these terms, which are hypotension, which is a word for low blood pressure. And we all have heard of hypertension, which is I have a high blood pressure. I think there's a quiz question that says, what's the definition of hypertension? And the answer they're looking is 150/90. And I got to throw the BS flag on that, but that's the answer they're looking for. Because there's just so many variables used to define hypertension. Age group, persons, blah, blah, blah. And hypertension cannot be defined and identified with one single reading. You have to have multiple readings over, a 2-week period. You get your average, give it to the doc, and he says, "Yeah, I think you're hypertension now. It's time to put you on some medications." Okay? Okay, we talked about this, estimating blood pressure. We said that if they've got a, I need to back up for that one. A radial pulse, their blood pressure is about 80. Femoral pulse is between 70 and 80. And carotid is between 60 and 70. So just remember 60, 70, 80. It's real easy to remember that. Okay, how often do you reassess vital signs? And on an unstable patient, you need to check them every 5 minutes. Now, I'll just tell you right now, you take out the word every, you put the letter Q on there, it means the same thing. So Q means every. All right? So if you see on a document Q5, the vital signs Q5, that means do what?
Every
Take
5
them
minutes.
every 5 minutes, okay? And for stable patients, you want to take them every 15 minutes or so. All right, I love this slide. And clearly, my opinion is you should not treat numbers, treat people. If you have a little mama and her blood pressure is 90/70, and I get there and go, "Oh my God, your blood pressure is 90/70. And so I'm going, I need to get some IVs in you, give you some fluid. She weighs maybe 89 pounds, soaking wet. Is that a pretty good blood pressure for her? And what's the best indicator that's a good blood pressure for her? You're going to hear this a lot in my class. Find out where she lives. Now, I'm not talking about her address. What am I talking about? Find out what her values are. Find out where they live. As I get older, my pressure may go down. And so now I'm not living at 120/80. I'm living at where? 90/70. I'm comfortable there. Don't be jacking with me. I like it there. My body's gotten used to that. That makes sense. Same thing. If you have a diabetic and we say normal blood sugars are 80 to 120, well, this person's been a diabetic for 20 years, they've reset their normal. Their normal is not 80 to 120, it's 150 to 160. So where do they live? Right over here. All right? So find out, and that's just a little slang, but it kind of works, okay? You want to be cool like me, you can do that. All right, perfusion. Skin color, temp, capillary refill. We talked about that a while ago, right? When you check their pulse, you want to check, hey, do I have a pulse? And or what? Capillary refill time. And or what? Skin temperature, what does it feel like? And skin color. Okay? And oddly enough, in EMS, we don't check temperatures a lot. We just kind of use the back of your hand to their forehead to see what they feel like to their arm, okay? You feel yourself. See how good you feel? Now put the back of your hand on the desk in front of you. Big difference, isn't there? 98.6, about 74. So my point is, you put your back of your hand on somebody's forehead and they feel like this, probably dead. Okay, skin color. Again, is it pink? Nice and pink. All right. Is it flushed? Is it pale? Pale, again, is colorless. Cyanotic is what? Blue, discoloration. And again, jaundice is kind of that yellow discoloration. Okay? So, be descriptive of what best descriptive they fit to you. The temperature could be considered hot. That means what? If the skin temperature is hot, it's going to be fever. It could be that they're knocked out their thermoregulatory system because they're overdosed on certain meds. Okay? A heat emergency. Warm is like us, cool, again. And cold are starting the stages of shock and or death if it's cold. All right, capillary refill, again, this is the test answer, right? What was the take-home message here? This is best used on what population?
Children.
There you go. Excellent. All right, what's the next one?
Pulse oximetry.
What's the next one beyond that? That's not important.
The respiratory system.
All right, we'll start that.
Circulatory.
Yeah, according to the
Oh yeah.
schedule, it says
Is it respiratory or circulatory?
Circulatory.
circulatory.
Oh, okay. So circulatory is not till when? I mean, respiratory is not till when? It's not tonight,
Respiratory is
though.
not till Monday.
All right, let's do circulatory then. Oh my gosh. That only had 40 slides. This one's got like a cajillion. Oh, only 11? Oh, okay. All right, circulatory system. Be there or be square.
Start down on the left.
All right, the circulatory system
Aha.
sounds like a system that's designed to do what? Circulate. And what's the word circulate mean? Move it from point A back to point A. Makes a circuit. Okay? And anything could happen in there. I could get a hole in the circulatory system. I could get the circulatory system which gets bigger. I could have a pump issue. I mean, there's so many things that can happen in the circulatory system. Okay? And please don't take this slide home or take this image burned in your head to go home to your significant other and say, did you realize that on the right side of my body I got blue blood vessels, on the right I got pink ones, so I got veins on this side, arteries on this side? No, they're just, it's kind of a matrix. But anyway, the circulatory system, if you look at it, is a closed loop system. And it's just kind of designed to make things go one direction and keep repeating the cycle. Okay? Can your circulatory system go the opposite direction? It can. It's not designed to do that. It can do that. If you have a heart valve issue, you have backflow issues, okay? You have an enlarged heart, you can have that happen to you. That's not normal. So again, it's designed to go one direction. This is kind of cool now. On this side, this being the arterial system, it's real simple to think of, okay? You have the left heart and you have the right heart. I'm sorry, right heart and left heart. Okay? You have the left side of the heart, which is designed to pump blood through the aorta into the arteries. And arteries are designed to do what? Carry oxygen and nutrients to the cells to keep them alive. Period. Okay? Now, they're going to do that, but they're also going to take that same blood from those cells and tissues that's been used as carbon dioxide waste and move them into the what I call the low pressure system, the venous system. Now the venous system in life is to do what? Finish the circuit and bring blood and CO2 and waste back to what? To the other side of the heart, which is the right side of the heart. This is my left, this is my right. Okay? So my left heart is going to pump it to the cells and tissues and keep it alive. Cells and tissues are going to use it, send it where? Back to the venous system, back to what? To the heart. Okay. Now, when this thing contracts 120/80, there's a lot of force there. So the blood vessels on this side are considered high pressure. It's the arterial system. It's pumping it. So these are high pressure. When it gets into this space right here called the capillaries, things slow down, even the pressure. So when blood enters the venous system and it's directing blood back to the heart, the venous system is considered what? It ain't a high pressure, so it's got to be what? This is why I say this, okay? On the inside walls of these arteries, on the inside of them, they're smooth. They're multi-layered thick, okay? They're designed to expand and contract. Okay, they're designed for high pressure because blood is being pumped directly from the heart into them. That makes sense? You with me so far?
Mm-hmm.
All right. Once it gets in the capillaries, what happens? The pressure is reduced. Okay? So it enters the venous system, and it's almost like residual pressure, and by gravity, blood's got to do what? It's getting pushed from the lower part of my body, where? Back up to the heart. Does that kind of make sense?
Mm-hmm.
Okay? So this pressure in this system is what? Low. Okay? What's the first thing I said a while ago? Blood's designed to do what? Go one direction to complete the circuit, right? Well, because this pressure is low here, what the good Lord did, He said, you know what? Blood is, the pressure here is low. So what I'm going to do is I'm going to put valves in the venous system. One-way valves. Blood's going this way, No valves in here because it's high pressure, right?
Mm-hmm.
Pressure's reduced. Comes in here. And so what do we start seeing in the inside walls of these veins? Valves. Blood pushes through, closes. Moves to the next one and closes. Why do we do that? Because it's a low pressure and preventing backflow. That makes sense? Okay. So, and this is kind of another way of looking at it. If I were to wrap a blood pressure cuff around the arterial system, what would my blood pressure be? About 120/80. There you go. If I took a blood pressure cuff and wrapped it around the venous system, what do you think my blood pressure would be? Any idea? About 110. 120/80. So what's the blood pressure on the venous side? Like 12/8. So does that kind of help you understand it's a low pressure system?
Yes.
Okay. Alrighty. There's the heart. And what's really kind of interesting about the heart is just a lot of stuff. But just this is a quick overview of the heart. Remember we said the heart is what? 4 pumps kind of sewn together, glued together to make what? What appears to be one big pump, but it's actually 4 pumps doing separate things. Okay? Now, the heart itself is kind of thick. Okay? And here's what I want you to understand. What keeps my toe pink? Why is that toe pink? Because I have an artery that started from the heart, eventually went down my leg, got smaller, and there's a small artery that you feel, dorsalis pedis pulse, with me?
Mm-hmm.
You felt that, so that's the artery. And what connects to that artery? Capillaries. And what connects to them?
Veins.
Veins, which sends a what? Back up to the heart. So you understand that, okay? So the answer is what keeps that toe pink and those cells alive is blood from the ventricle pumped it all the way down there. So here's my question. If this heart here is muscle, this is muscle, what keeps us alive? Heart pumping blood through it via the arteries and the veins, right? What keeps this heart muscle alive?
Heart, arteries and veins wrapped around in the muscle of the heart.
There you go. A lot of people think that by virtue of blood flowing through the ventricles, that's perfusing the heart. It ain't so. Okay? What happens is blood is being pumped through the heart, through the chambers, and off the aorta. The first set of vessels to branch off the aorta are called what? Coronary arteries. And so they wrap around the heart, and so there are arteries there. And there's also what? Anytime you have to have an artery, you have to have what?
Vein.
A vein. One sends it to it, one brings it back. And what connects the two? Capillaries. Very good. Okay? So, when people have heart attacks, you've heard that, what's going on? Physiologically, what's going on to this heart?
Something's out of
These coronary arteries are what? There you go. So if there's a branch right here and there's a blockage right here, blood's not, or actually this artery, if it's blocked, let's just put it right here. You have blockage right here. So this artery is perfusing what? This section of the heart muscle. So when people have a heart attack, the whole heart don't die. What dies? Or what has the opportunity to die? Let me repeat that. The segment of the heart that artery that's blocked is perfusing. That makes sense? It's just like me plugging up an artery going to my hand. Well, that part of the hand that's being perfused by that artery is going to die. Or has the opportunity to die. Okay? Real quickly, you have two huge veins that are bringing blood back to the heart, to the right heart. Veins carry what kind of pressure? Low pressure. What kind of blood? Deoxygenated. Okay? So, this is superior, this is inferior. So, all the blood flow coming from the lower part of my body come via the inferior vena cava. From the top side, my head and neck, is something called the superior vena cava. They enter the what? The right atrium. Okay? And so that starts the process of getting blood from the right heart to the lungs, from the lungs to the left heart, from the left heart to the body. That's kind of how it works. All right. And these are the coronary arteries we talked about. You see how they're starting to branch off the aorta? The heart is kind of cool. Actually, it's very cool. One of the coolest guys around. But the heart is really cool. It says, you know what? From the minute you're born to the day you die, I'm going to work. I'm going to continue to work for you. I will never stop. You know what I'm saying? But it says, the only thing I'm asking of you, body, is that I'm going to get the first and the best and the freshest blood available. So the first blood vessels that branch off the aorta feed what?
The heart.
The guy that's always working, the heart. Okay? Unfortunately, this guy's been smoking, he's a diabetic, and he's been eating chicken and hamburgers for the last 60 years and eats a pound of bacon almost every other day. And so he develops what? Plaque. Plaque does what to the inside of that blood vessel? It sticks to it, makes the diameter what? Smaller, and eventually will continue to close. And so you may have a 60, 80, 90, 95% occlusion. Okay? And that's when they go, well, we got to fix that. How are we going to fix it? Well, we can do bypass. We can kind of squirrel it out of there. We can put a stent in there. There's a lot of things they can do. All right? Okay, so I think we beat that one to death. All right. You guys are going to have to understand blood flow to the heart, period. Okay? There's probably going to be about 3 or 4 questions on your test relating to, okay, blood just entered the right atrium, where does it go next? So you'll need to be able to figure out the routing mechanism, okay? You're not going to get it tonight if you don't know it already, but it's something you need to look at. So again, blood comes from the inferior and the superior vena cava, and they enter what?
Right atrium.
The right atrium, okay? From the right atrium, remember there's backflow preventers. So the good Lord put valves in your heart, okay? And the way to remember them, it's the way they remember in med school, is TPMA. When I go to the toilet, I hope there's paper for my ass, okay? Now, okay, and this is the way it goes. Right atrium to the first valve, tricuspid, okay? It goes into the right ventricle. The right ventricle is going to spit it out to, it wants to send it to the lungs, so let's call that vessel between the heart and the lungs pulmonary, okay? So it has to go to the next valve called the pulmonary valve, but that vessel is going to be a pulmonary vessel, and the way to remember it is this way. Blood vessels that go away from the heart are arteries. Blood vessels that bring blood into the heart are called what?
Veins.
Veins. Very good. Now what's kind of interesting about this? Well, this is what's interesting. Right now this is all blue because this blood is what? Deoxygenated. Okay? And so this ventricle is contracting and sending blood through the pulmonary valve into a pulmonary.
Artery.
Why is it an artery?
Because it's going away from
Because the blood vessels going away from the heart are what? Arteries. But here's the question. Arteries normally by nature carry what kind of blood in them?
oxygenated.
Is that true today?
Yes.
No, it's not.
No.
This is blue. It hasn't gone to the lungs yet. So this pulmonary artery is carrying what kind of blood? Deoxygenated. Hasn't gone to the lungs yet. When it gets to the lungs, what happens? The respiratory system works its magic on them, and it oxygenates that. And so it's sending a blood vessel from the lungs back to the heart, and blood vessels go into the heart are what? Veins. And from the lungs, so it's a pulmonary vein, okay? And what kind of blood is that?
Oxygenated.
Because it came from where?
The lung.
The lungs. There you go. So there's only one other situation where you're going to find an artery carrying deoxygenated blood. That's in the umbilical network. We'll talk about that later. Okay? Anyway, so we have a pulmonary veins that want to bring that oxygenated blood into this side of the heart. What's the upstairs apartment called?
Left atrium.
The atrium. Very good. In the atriums, there's a little valve in here, the M, which stands for what? Mitral valve. Okay?
It's the bicuspid valve, right?
Exactly. Then the ventricle contracts into the aorta, but there's a valve there called the aortic valve, the last valve, and it sends it into the aorta. Okay? So that is kind of blood flow to the heart. That's all you really need to know about, blood flow to the heart. And the way the questions are going to be situated is you're going to say, blood has just left the right ventricle. Where is it going through now? Is it going to the pulmonary artery, or is it going to the pulmonary valve next? It just left the ventricle. The answer is the valve first, then there you go. All right. Now, this is what's kind of interesting. What is it that keeps the heart pumping? Remember the heart said, you know what? I'll beat for you the rest of my life. What is it that keeps the heart pumping? Okay. So we know what the heart does. It pumps, right? Okay? But we also have to have electricity in it. Because the answer to your question is, what keeps the heart pumping is electricity. It's a property called automaticity. In other words, the heart generates its own electrical impulses. Oh my gosh. Where is it coming from? Well, I didn't see an extension cord hanging out of you guys. So how do you keep that heart charged? How do you keep electricity running through it? The good Lord said, well, you know what? What does this person have a lot of? And the answer is what? Water. Okay? Now, what kind of water do you have? Well, you have electrolytes like sodium, potassium, calcium. He said, well, I just make some of these and give some of these a positive charge and some of these a negative charge. And that generates what? Electricity. So let me ask you this. If one of your electrolytes is off, like your potassium levels, is that going to jack with your electrical conduction system? The answer is sure it is. Okay? So that's why it's important when old people, for example, when they go into something called congestive heart failure, their heart starts to get bad, okay? The doctor puts them on something like Lasix to make them pee it all out. Well, guess what, doc? You gave them Lasix, but they're not only peeing out sodium, they're also peeing out what? Potassium. So that person, the doc says, well, I need to give you a potassium supplement to offset that. Because if I don't, it does what to your electrical system? It jacks it up. Okay? So, anyway, the electrical conduction system starts with something called the SA node. Okay? In other words, where did that wall plug right here, where'd the electricity come from? Where's it coming from? Electrical plant. Now, how many gajillion volts of electricity are at the electrical plant? Bunch. How many are right here? 110. So between those two is what?
Transformer.
Which do what? Reduce it. Very good. And so what you need to do is think of the conduction system as all the power's coming in here. When it gets down to here, it really slows it down. Okay? In other words, this is what's called a pacemaker. And this primary pacemaker is set to fire at 60 to 80 beats per minute. You with me? It comes down here and connects right here in something called the AV, and that's reduced, 40 to 60. Comes down here, and it's what? 20 to 40. See what I'm talking about now? Now, electricity doesn't start here and go up that way. It started from the plant and came down and reduced down. So it starts high, and it gets kind of gets slower right here. Now you see the predicted pathways. The atrium kind of came right here, and it went over here. This is just kind of FYI. Sometimes people have what's called an accessory pathway. In other words, they have a little branch that comes over right here. And for the majority of the time, that electrical impulse comes in and goes left instead of right into the accessory pathway. You with me? But every now and again, it gets squirrely and says, you know what, I think I'll just go right today. So sometimes when people have accessory pathways, electricity comes down there, it jacks with the heart, and their heart rate gets really, really, really fast. In other words, their heart rate gets up to like 300 beats per minute. Now, do you think that's going to jack with their blood pressure if their heart rate is 300 beats per minute?
Yes.
Do you think they're going to be short-winded with a heart rate of 300 breaths per minute? Why? Well, the heart's beating faster. Should that be better?
No.
Because why?
Stress.
Not the answer I'm looking for. What else?
Your lungs can't keep up. You're
Okay.
trying to keep your lungs.
You're putting too much pressure on the lines.
Real quick.
The faster it beats, the less
Let me
blood
just
pressure.
explain something called Frank Starling to you, okay? Frank Starling works like this. It's his rule, so he gets to attach his name to it, okay? But basically, just think of it in simple terms. When blood comes into the atrium, it passively comes in, okay? And it opens the first valve. So this sucker, being the ventricle, fills about 80% of its capacity. Okay? But we're not at 100 yet, right? So in order to get to 100, what's got to happen? This pump, being the atrium's got to contract. When it contracts, it does what? This gets this from what? 80 to 100%, right? So that ventricle is nice and full. You with me? So when that ventricle is nice and full, it's going to contract better. Here's the example. Frank Starling rule basically says the greater resistance against the inside of the wall, when you expand it more, it contracts with a better force. Let me give you a simple example. I have two balloons. Here's one for you, and here's one for you. I want you to just go. Just put a little bit of air into that balloon. Okay? I want you to take your balloon and keep blowing on that sucker until it almost is going to pop. You with me? Now, when I ask you to hold that balloon by the neck and open it, what happens? Woo.
Pretty much.
A little bit of air comes out. How far is that going to push blood? Not very far. If there were blood in your balloon and I released it, you put so much pressure on that wall of that balloon, so much pressure on that wall of that ventricle, that when it gets ready to contract, it contracts with a great deal of force, right? And it has to, because it's doing what? This ventricle is sending blood where? Upstairs to the lungs. This ventricle is sending blood where? To my toe. So does it make sense that these suckers got to have a lot of resistance against them? And that's kind of how it works. All right? Okay. We talked about these right here. Yeah, we know this stuff right here. All right. I think this is pretty good. A little cutout right here. There's a couple of things missing. What's missing? Heart. What's the biggest blood vessel coming out of the heart? Aorta. Aorta becomes what? Artery. As the arteries get smaller, they become what? Eels, arterioles. Okay? Arterioles are going to dump blood into the capillary bed. What happens in here? It's feeding what? Cells. Okay? It's dumping what? Oxygen and glucose and nutrients. Okay? And what enters the cellular body again? Waste. And it does what? It enters the venules. Okay? The vein. And see those valves I was talking to you about? Why are those valves in there?
So then
Simple. Blood pressure over here is what?
high,
Blood pressure over here is what?
low.
Okay? And plus I got to pump uphill. And the pumps up here, if I had a pump down there, guess what? Would I need valves on this side? No, because there'd be an equal high pressure on both sides. All right? All righty. And so aorta and the pulmonary arteries, carotid, and we talked about these. I think it's kind of slow. All right. Again, you're not expected to know this stuff. I do want you to know the major, like pulse points: carotid, brachial, radial, femoral, popliteal, dorsalis pedis. What was the last one? Tibia, behind, posterior tibial. Okay. All righty. Okay. So again, what do you have to get perfusion to my toes? You have to have a heart. Heart has to be working right. If it's working too slow, is there a problem?
Yes.
If it's working too fast, is there a problem?
Yes.
Okay. I guess what I was kind of got off track a while ago. Well, the question was, if your heart is beating 300 beats per minute, is that a good thing or a bad thing? Now that we've gone over Frank Starling's You understand why it's a bad thing? Why is it a bad thing? Because the heart's doing blah, 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 the ventricles blah, 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 blah. What aren't they having a chance to do?
Fill up.
Stretch and get nice and full. So are they going to have a low blood pressure because the heart's just doing like this?
Mhm.
Yeah, they are. So, and I think we kind of beat this to death a little bit. We know that. All right. What's next?
Cardiovascular emergencies.
Cardiovascular, and there was what? Oxygen saturation? And that's the only other one? Is that right?
Aspirin and nitroglycerin.
Aspirin tonight?
Mm-hmm.
Dang. Let's go over nitro since we just talked about some hard stuff. All right, nitroglycerin, as we've kind of talked about that briefly, we talked about nitro. Nitro is actually a really, really good drug. Obviously, it's got a purpose in life. Its mechanism of action, again, how it works is it relaxes vascular smooth muscle. The effects of it, it dilates blood vessels. So relaxing the vascular smooth muscle, the muscle around the blood vessels, it relaxes them. So what happens to the vessels themselves? They stretch. But here's the problem with nitro. Nitro has what I call a systemic effect as opposed to a localized effect. Okay, example. I get stung by a bee and I get a big raised area and it hurts just in that area. That's a what? A localized reaction. Okay? Versus a systemic effect, something that affects the whole body. Nitro does that. In other words, we give nitro to do what to the blood vessels? To dilate them. Which blood vessels are we trying to dilate? The coronary blood vessels. But it can't selectively just dilate the coronary blood vessels without doing what? Dilating all of them. So again, what happens in a nutshell is we take our blood vessels in our body and we make all of them bigger. You with me?
Mm-hmm.
So when I make all my blood vessels bigger, I have the same amount of blood I had a while ago, but they're just in a bigger container. It would be like your big drink right there and this drink right here. Okay? Let's say this little jar right here represents the entire volume of all your blood vessels combined. You with me so far? And so now I have this full, and I take that and I put it in your cup being empty. Your cup representing the same blood vessels, same circulatory system, but now they're what? Dilated. So the level on that which was full on here is about on the halfway mark on that. So that kind of equates to blood pressure. Okay. So again, when you do that, when you make the blood vessels larger, you make the container larger, you drop the blood pressure. It does something called decrease the preload. Preload is just basically blood flow going back to the heart. If I'm a sick heart, because I'm having a heart attack and my muscle is sick and it's not contracting as well as it's supposed to, do I still want the same pressure going to it, or do I want to decrease that preload to release the workload of the heart? That's the answer. You want to decrease the preload to decrease the workload of the heart. Okay? And again, it decreases afterload because there's less to push out. Okay, and so the target of giving somebody nitro is to do what? If I were to give you that little diagram of the heart a while ago and I had that little blood vessel that was occluded or partially excluded, I just gave nitro, which did what to the circumference of that blood vessel? I made it bigger. Okay? When I made it bigger, more blood flow to get through. And that's what we're trying to do, is increase blood flow to the ischemic. Ischemic meaning that blood flow to that heart muscle is decreased, that tissue is starting to get sick, and it may go from something called ischemia to infarction. Infarction means death to the tissue. Okay, indications are ischemic chest pain. In other words, somebody's having chest pain, nitro is what you're supposed to give them. Contraindications, this you need to know, absolutely. In other words, don't just give somebody that's having chest pain nitroglycerin if their blood pressure is less than this. This is your marker, okay? Because if their blood pressure is less than this, we drop their blood pressure even more. Let me give you an example. If I'm sitting on a blood pressure of 150 over 80, and you give me nitro, one nitro can drop your blood pressure by 50 points. So if I was sitting on a 150 and you drop my blood pressure by 50 points, my blood pressure is now what? 100 over 80. Does that make sense? And if I have a lower blood pressure, am I sending less blood flow to the injured heart, or am I sending more blood flow to the injured heart? The lower blood pressure means less flow. So is that ischemic heart tissue going to get better, or is it going to get worse? It's actually going to get worse. Okay, ED meaning non-emergency department. It means erectile dysfunction. So ask the question, okay? If they've had any ED drugs in the past 24 to 48 hours, and depending on what it is they're taking, some of those suckers have a 72-hour window of opportunity. Anyway, if they've had any of those drugs, you don't want to give them nitro. Why? Because they both do the same thing. Okay? They dilate blood vessels. That's how ED drugs work. They open the blood vessels, improve perfusion. Okay? So if you give two drugs that are essentially doing the same thing, you're going to cause something called irreversible hypotension. Right? So ask the question. All right, forms of nitro. They come in tablet, which is something that you stick underneath the tongue, a spray, patch, and paste. In other words, this is the paste right here. So what happens is they've got a little, like a clear window, little patch, and they take 1/2 inch to 1 centimeter of nitro paste, like toothpaste. They put it under skin, put that Band-Aid kind of thing over it, and it's transdermal, meaning that it absorbs to the skin via or absorbs to the body via the skin. Transdermal. Be careful with that. When you handle nitro, make sure that you're wearing gloves, because what did I say nitro was? Transdermal. It soaks through your skin. It soaks through the sublingual tissues of your mouth. Okay, so it'll dang sure get through your fingers. Why do I caution you to be careful with that? Because you're going to get a hit of nitro. So what's it going to do to you? Drop your blood pressure. What's it going to do to you? Give you a headache. Okay? And there it again. These are the tablets we talked about. This stuff, you see how it's in a dark bottle? It means it's light sensitive. It's also air sensitive. Here's a caution. This person's got nitro. You get in their home, and they're taking nitro. They've got chest pain. This bottle is open on their dresser. They said, I just took 3 nitro, and I'm still having chest pain. So the thing you're thinking of is what? How long has that bottle been open? There's a lamp directly on it. Okay, so what do you think's probably happened to the potency of this nitro? It's probably not any good. Okay, if they didn't produce a headache, numbness or tingling underneath their tongue and lips, it didn't drop their blood pressure, and it didn't relieve chest pain, how good is a nitro? Probably not too good. Okay, so what I'm saying to you, even though they've had the max dose, which is 3, be prepared to do what? Give them some of your nitro. There's a dose. It is 0.4 milligrams. So each one of those tablets is 0.4 milligrams. Okay? The way you can give it is Q5 up to 3. So you give nitro every 5 minutes to a max total dose of 3 tablets or 1.2 milligrams, right? Is that right? 4 times 3 is 12. And same thing with the tablet or the meter dose spray. Now guess what, guys? We do not give nitro via paste. You with me? That's a test question. How do we give nitro? How are we in this room allowed to give nitro? Sublingual, which comes in what form?
Tablet or spray.
Tablet or spray. That's going to get some of you on the test. Again, I said you can repeat it every 5-minute intervals up to a max dose of what? 3. Okay. When would you not give a second dose?
If the blood pressure is low.
There you go. If their blood pressure drops more than you want it to. The side effects again are low blood pressure. They can have opposing tachycardia, and they could develop a headache. And/or NV, which is nausea, vomiting, and flushing kind of sensation. Why do they get dizziness? Because their blood pressure drops. All right, it says do not give them if the patient is standing, because they may do what? Pass out. Tablet form, protect the potency, make sure it's a good agent. Store in the original brown bottle. This is not one of those tablets that you want to take and put in the Monday through Sunday kind of carrier, okay? Because A, you're just taking it out, it's air sensitive, and again, it's light sensitive. Okay. Again, potent nitro will give you a headache. And let me go back a second, because that made a test question. Burning sensation underneath the tongue. And so that's what nitro is going to do. All right, then. Very good. I guess we'll see you Saturday.
We meet in here?
Saturday.
Was this me?
Yes, when's our next quizzing due?
What's the next quiz?